Assalamu alaikum. Good morning, good afternoon, good evening, everyone. Thank you for joining. This is one of our extra webinars for the month. So thank you for giving us one more weekend. Today we have a new speaker, and we are really blessed to have Dr. Elizabeth Kasher. She is an experienced medical educator with extensive expertise in clinical skills assessment, including both simulation and workplace-based approaches. After holding academic and clinical roles at several institutions, she established an independent consulting practice, collaborating with organizations in the US and internationally. Her work focuses on curriculum development, faculty development, learner assessment, and program evaluation across the medical education continuum. She has published widely, co-edited a book on OSCE development, and regularly delivers workshops and presentations on performance-based assessment worldwide. Thank you and welcome, Dr. Elizabeth. The floor is yours.
Well, thank you very much for this nice introduction. And I feel very honored to be here to share with you some of the ideas and some of the challenges that we face with OSCEs. It's a very special topic for me. I have been doing OSCEs for a long time. And I'm sure that there are some of you here who also have been very much involved with OSCEs. But in general, it's a performance-based assessment that really has captured the world. I mean, it's in just about all continents. So it's something that we all need to think about more clearly and dive deeply into how to make them as successful as possible. So I will share my screen and share my slides, but I hope this will be a very interactive session. We have a few polling questions, and also I hope that you will just unmute and share your thoughts as well, or also put them into the chat, but I won't be able to see the chat while I'm sharing the screen. But let me get started. So feel free to share, just unmute and talk. It should be very interactive. Okay, I'll start sharing my screen, my slides. And here they are. Can you see the slides?
Yes, we can.
Okay, very good. I'll put it then into presentation mode. Okay, you see them, right? All right, so we will be talking about OSCEs, objective structured clinical exams or exercises, and we'll discuss some of the current trends or current concerns, and also think about the future. What are our future opportunities? And my name is here and my email as well. If you have any questions afterwards, please feel free to connect with me. So objective structured clinical exams, that was the original title, and that represents different stations that learners or examinees go through. And the idea is that everybody has exactly the same challenges. They face the same challenges in each of the station. It's time limited, so they rotate on a continuous basis through this circle of stations. Sometimes there are so many stations as you see here on this image, but usually they are much less. This is a 10-station, was a 10-station OSCE I was involved in. But over the years, there has been some concerns about how objective it really is. And so some people look at the O now as standing for observed rather than objective. And also initially it was seen very much like an exam, an assessment, but more and more people look at it as a formative assessment tool. So it's a learning opportunity, an exercise, and experience. So the E also has changed over time into exercise and experience rather than just exam. And many of these OSCEs include simulated or standardized patients, and that also has changed because stations no longer are just clinical challenges, but also sometimes interprofessional challenges or other kinds of encounters that require some important skills. And OSCEs are a skill assessment. And here you see a patient and a healthcare provider, and I will ask you later whether this is a healthcare provider, a clinician acting as a patient, or a non-clinician acting as a healthcare provider. So you will see those two pictures again. I should also mention that there are many different terms being used for OSCEs. Sometimes in the literature, and it's quite a nightmare for anyone who is doing a literature review, they're called multiple station exam or exercise, clinical skills assessment, comprehensive clinical exam, clinical practice exam, objective structured clinical assessment. Sometimes they are done in groups, so individuals rotate in groups through the different stations, and we often call it GOSCE, group-oriented structured clinical exam. And an OSCE is a term for teaching exercise. So same structure, but the focus is on teaching. In this case, we'll just talk about OSCEs, but it stands for all these other types of assessment tools, formative and summative, that are being used in health professions education worldwide. So think about when you hear the word OSCE, what words come to mind? Maybe you can put that into the chat, and maybe Sakina can say, we wanted to do a word cloud, but that didn't seem to be feasible with this program. So any thoughts you have, what words come to mind when you hear the word OSCE?
I got one objective from you. Okay.
Objective, yeah, okay.
Summative exam,
Yes, exam.
practical exam, clinical, reliable assessment,
Yes,
decrease subjectivity, but OSCE also has subjectivity, practical exam.
yes. Okay, so the idea is really that to make it practical, to make it close to reality, close to a real clinical to a real situation, real life situation. These are very important characteristics. That's definitely an effort that we put into these kinds of projects, that we want to make them as realistic as possible, even though they are a simulation. Okay, so let me ask you now, and I think we have a poll question here. How many years have you worked with or experienced OSCEs? You may have taken an OSCE, you may have worked as an SP in an OSCE, or as a faculty, or organized an OSCE. So let's see how how much experience do you have with it? And I can see already that there's a good variety in this group. So any more? Yeah, so maybe I can see, and I should maybe end the poll here.
Okay.
Is that okay?
Yeah.
And share the result. Can you see the result?
Yeah, I have less than 1 year 4 and 1 to 5 years 7,
Yes.
6 to 8 years 3, and more than 10 years is 6.
Yes. So really quite a good variety of experiences in this virtual room. And that will be a good opportunity to share your experiences and to share your expectations of what OSCEs can and cannot do. Thank you. So let me move along. Oh, I see somebody crossed out the one, but maybe this is just a mistake. Okay, I don't know how that happened, but it happens. So here, this is our agenda. So we first talk about where have we been, then where are we now, and then where are we going. I see that I don't know how we can get rid of this little red mark, but here we are.
Unshare
So,
and share the screen.
I have to stop sharing the screen. Well, maybe I can
It's
do that
okay. Yeah.
in a minute. It's not so distracting.
No, you can just erase it if you can. Or whoever
Yeah.
put it there can erase it.
Yeah, whoever put it there, please erase it. So these are the objectives for our sessions, and I'm glad we have such a international group here because you'll be able to share some of your experiences, and I hope by the end you can describe global efforts to integrate OSCEs in health professions education as assessment and as a training tool. And then also discuss the impact of education on science and best practices in OSCE creation, and explore some of the uses of technology for enhancing OSCE development and implementation. So hopefully by the end of this workshop, of this webinar, you'll feel comfortable doing these 3 things. So let's start out with where have we been? So here are 3 people who have been very instrumental in developing OSCEs, the who is who in the OSCE world. And let me ask you, anybody knows who the number 1 is? Who wrote the first OSCE article? Please just
Hardin.
unmute.
Harden, Professor Harden.
Yeah,
Hardin.
Professor
Yes.
Harden. Excellent, excellent. Yes, that is Ronald Harden.
My
And-
university mate. from
I'm sorry?
Dundee. My university mate from the University of Dundee, Scotland.
So you know him very well. Yes, he's
Well, I
from
mean, I didn't know him then because we were all struggling in those days. But later on, of course, when we
on.
medical education, yes.
Yeah. Well, Ronald Harden is the
He's the
inventor
pioneer.
of the OSCE
He's the pioneer of medical education, in my
and
view.
a pioneer of medical education in general, not
Yeah.
just OSCEs. Yes, definitely. And he is, if you go to Amy, you will surely meet him, or if you go to one of the Ottawa conferences. So anyone knows who number 2 is? He created the first Ottawa conference, and it was in Ottawa, so it was in Canada. And the conferences still are called Ottawa conferences. And this year, actually at Amy, it will be integrated into the Amy conference. So the Ottawa and Amy conference will be together. And his name is, anybody knows? No. His name is Ian Hart. He's no longer with us, unfortunately, but he has been very instrumental in promoting OSCEs by developing these conferences that focus on performance-based assessments and OSCEs in particular as well. And what about this number 3? Anybody knows who number 3 is?
Gilbert or something.
Huh? Sorry?
Gilbert?
Gilbert?
No, his name is Howard Barrows. And he is the inventor of the standardized patient, or initially it was a simulated patient, and then it was programmed patient. And so it went through various iterations of the name, but standardized patient then became, or simulated patient in a more, in European and Asian context, is more called simulated patients, is what he is really very famous for. He also is unfortunately no longer with us. But in the meantime, SP has also changed to be not just patients. The P is not just for patients, but for participants, because the topics that are used in OSCEs and other educational endeavors that use SPs, it's not just about patient care. It has become much, much more diverse. So yeah, and that was in 1964 that he wrote the first article on SPs. So it has a long history. And if you look at the Medline citations, as you can see, there are over 3,000. And this is surely an underestimate, because, as I had shown before, often publications use different titles, different names for their event, which is an OSCE, but they developed some local names to maybe distinguish their exam from other exams. But as you can see, there's quite a large number of literature that has accumulated on this topic. So where are we now? Here's a selection of OSCE or GOSCE or OSTI topics that I've been involved in, some of them. But what about you? Maybe you can share, unmute and share what topics have you been involved in. Some of them are general clinical skills, some are specialty areas, some specific clinical skills, educational skills, teaching. What kind of OSCEs have you either experienced as a learner or experienced as an organizer or as a faculty? Anyone? Are you putting it in the chat maybe?
Yeah.
Oh,
I got
okay.
professionalism, communication
Professionalism.
skills, communicating prescriptions to patients,
Okay.
communication skills again.
Yes,
Can I share my experience?
please.
Yes, I am actually Mona Abu Saud. I am a professor of internal medicine and endocrinology at the Faculty of Medicine at Alexandria University. So here since a very long time, maybe since early 2000s, we have been examining our patients after their rotations in the form of OSCEs, and at the end of the academic year also, through short cases as well as OSCEs. In internal medicine and in endocrinology, of course. And I was also working at the Faculty of Medicine Beirut Arab University in Lebanon, where we started implementing interprofessional education. So this was back in spring 2013, and there we started. The Beirut Arab University administration formed an IPE committee in which coordinators from the various sharing medical faculties were included, and I was representing the Faculty of Medicine. I was responsible for creating actually the interprofessional education case scenarios.
OSCE.
Yes, which were done first as case-based learning in the classroom, and then in the second part of the course, they were implemented in the skill lab. through case scenarios that were included acute cases on a mannequin, high fidelity or mid fidelity mannequin, but then we started also including chronic cases through using SPs in the who represented either the patient himself or herself as well as the family member. All right.
Yes.
And then I created I used the TOSCI checklist
Yeah.
from the Canadian institution, and I used also designed an ideal management checklist for grading the student.
Yes.
And
Yeah.
that's it.
So that actually is an interesting point that you're bringing up. And the issue is that OSCEs have been developed in really all healthcare professions at this point, and are sometimes a requirement for some of the fields as well. And interestingly, the checklists, the evaluation forms that we use for the OSCEs also sometimes can be quite complex if you have multiple learners from different professions working together. So thank you very much for bringing this up. It's very important to think it's not just something for one field, but for every field, every health profession education field. And it's also for interprofessional efforts, a very important tool that we have for teaching as well as for assessment. So thank you very much for your contribution.
Most welcome, madam.
Well,
Yeah, and maybe I can just, in order to move forward, I can just also share, in case you haven't done an advocacy OSCE yet. This is one that I'm involved in. It will be a fully hybrid OSCE, international, with 2 stations will come from Philadelphia, from the US, and 1 station will come from Qatar. Which is in the region that many of you are in as well. So this is just, sorry for the advertisement. I'm one of the co-chairs of the conference, but I think there will be another opportunity to experience an OSCE, and this will be about advocacy. So moving along, OSCEs have many different elements, right? There's the organizers, they have to develop a blueprint, instructions for everyone, the schedule, the standardized participants, the tutors or the faculty, the observers that evaluate the performance, and their staff as well, the timekeepers and others who help move the OSCE along. And of course, there are the learners. So it's a pretty fairly complex activity that requires a lot of different players. And as an organizer, one needs to keep all of these, keep the complexity in mind. Usually there is really a spectrum of expertise that is needed to successfully plan and implement such a program. So there are people who have the content expertise, usually they're clinicians, and then there are people who have the process expertise, and that can be educationalists, and sometimes people have both together because they have been working on OSCEs for so long, so they have developed this significant amount of process expertise as well. But it's many people working together to create such an assessment or teaching tool. And so teamwork is critical in organizing OSCEs. And the other thing that I think has come much more in the forefront is the importance of the target group, of the stakeholders. And this was an OSCE station at Drexel University, which is in Philadelphia. And we developed an OSCE station about microaggression and racism. And so we also showed the instructions for the SP, and we created a video for it as well, to the learners, to those, not those who were going to take the exam, but who are already beyond that in terms of their training. And we learned some important things that maybe some of you can also relate to. For example, in terms of language, we use the term troublemaker in the script for the SP, but that's not used by students. They also were informing us in this focus group that we had with them that what is socially acceptable behavior, and they mentioned that racial slurs occur only in older generations, so we had to also keep that in mind, and that students avoid talking to peers about these topics. So we also had to think about how to structure the station that it would be accessible to the experience of the learners. And finally, we mentioned that somebody watched something on TV, but the students said that they don't watch TV. So to make it real for them, it was very helpful to get their input. And also in the same idea of making it real for the learners who will be going through this exercise or this exam, it is also more and more common to inquire with patients or families about how their life experience is with certain illnesses or certain conditions, disability, for example, so that we can make it really representative of the problems that the learners will encounter in the real life world. So getting input from the target group and from others that will be very important. It has become more and more important. Some years ago, I put together this comparison. It's a chapter that I've been involved in as well, and I'll show you a little bit more about that afterwards. There's also the Association for SP Educators. They developed some standards of best practice, and that is also an international effort, and the SP website includes translated standards of best practice, and I know that they're working on the second edition of that now as well. But anyway, it's more and more as the methodology matures, it is important to think about what is the best way to do it and what are standards that we need to uphold the development of such programs. And then Furman, she wrote an article. She was one of the people involved in the National Board of Medical Examiners in the US, the NBME, who has developed this as a requirement for all medical graduates in the US. And I know it has been also used in other countries. And together with some other people who developed national exams, they also came up with some important quality assurance requirements or quality assurance criteria. So comparing those in regard to station development, it's clear that we have to be very careful that the stations are training level appropriate, so that we target the exact level of training that the examinees or the learners have that will come to this OSCE. And another important thing that is also emphasized, the importance of keeping it real. So we need to make sure that it is as close to the real world as possible, even though it is a simulation. And the simulation has its many benefits, including the opportunity to be have a safe space where you are not hurting somebody, hurting a real patient, for example. But it still needs to be kept real, so that the skills that are being taught in this fashion or that are being assessed approximate the real life performance. There's a lot of preparations needed for OSCEs and for developing the different stations. And typical encounters, they just required some instructions for the learners and for the SP. But there are also some stations that may be observation-based. And then it is helpful to also maybe have a video of what the learner is supposed to have seen, observed before they enter the room, to make it more, to help them engage in this scenario. And there are other stations that I've also been involved in that are personalized for individual learners. So they can relate, for example, to biases and microaggressions and other kinds of difficult situations that learners need to learn to deal with. And I see somebody is asking, has raised their hand. So let me just finish this. So in addition to getting the instructions, you also need to have specific triggers for each individual learner, so that they can experience the same rejection by a patient, for example, for something that is meaningful to them. And then you need to be sure to match up the triggers with the right learner. So Alam,
Yes, good evening. It's just referring to the point to keep it as real as possible.
Yes.
Have you some experience of using real patients in OSCE?
Okay. That's a good question. And initially, in some places, people are engaging real patients in OSCEs, and sometimes it's necessary because they have certain physical findings that cannot be simulated so easily. Personally, I have been very concerned about using real patients because it can be a very stressful experience. You don't know what the learner will do. And we need to also think about the safety, psychological safety, and the physical safety of the SPs. So, and also we know that if they don't feel comfortable, for some reason, they may not be as consistent in their case portrayal as we want them to be. So I have not found it very helpful to use real patients. They come there for a different reason than the SPs, who are there to portray a specific case. But real patients are really critical, like I mentioned before, to inform the case development, to make sure that the script that we have for the SPs is realistic, that this is similar to what a real patient would experience.
Actually,
Can I please comment?
we have used the real patients, especially for physical signs.
Yeah.
For example, we have let's say abdominal examination, and we have let's say number of patients, maybe 8 or 10 patients of thalassemia with hepatosplenomegaly. So frequently we keep on changing the patients to keep them comfortable. And the students, I mean, although it's not exactly same, but they are looking for the similar findings. And all these patients have hepatosplenomegaly. And I think we have been doing quite successfully, and I don't think there was a lot of discomfort to the patients in this situation. Similarly, I'm talking about pediatrics. And similarly, we have been using patients with congenital heart disease, for example, because every patient may not have exactly the same sign, but there would be similar things. So that's our experience here in Malaysia.
Yeah,
Yes, can I please comment to that,
sure.
Professor Elizabeth? Yes, in Egypt we're doing the same thing. We're using real life patients for endocrinology. For example, for thyroid examination, you cannot. Of course, it can be done. The technique, I mean, on a normal, let's say
Yeah.
SP. But usually we have patients with Graves' disease, with eye signs, and such things. We have also acromegalic patients. You cannot really do the OSCE on SPs in that regard. And as well, and I have another experience as well, being a PACES examiner, international PACES examiner. This stands for Practical Assessment of Clinical Examination Skills for the Royal College of Edinburgh. We have a center here at the Alexandria Faculty of Medicine in Egypt where they have a carousel. The carousel is like some sort of OSCE, but extended with extended time. And we are using also we are using both the SPs for example, consultation, the consultation station or the communication skills station, and we are using real life patients where the students or the examinees have to, for example, detect a cardiac lesion, a lesion on the lung, an abdominal lesion, like Professor Malik mentioned, and so on. So this is my experience as well.
Well, I know that they have been used in different places, and the first OSCE I worked on, we had both real patients and we had also simulated patients. I mean, it is possible to use them, and as I mentioned before, if you're looking for certain findings, it is difficult to simulate that sometimes. But actually, there are some more and more technological options that I'm also going to mention here that will provide some more flexibility also in that respect. Not for all physical findings, but for some physical findings. So definitely it's a consideration to have as well. So maybe you can just move on.
Sorry, there is another question on chat.
Yes.
So even after the efforts to make the OSCE to mimic a real life setting, the competence demonstrated by students when observed does not translate to performance in true hospital settings. Any suggestion to overcome, please?
Well, it is a simulation, so it is an opportunity to demonstrate. It's a performance-based assessment. You can demonstrate your skills competence, but there are other factors that happen when you are in a real-life setting. There is more different dynamics going on that you can control in a simulated setting, but that you can't necessarily control in a clinical setting. So definitely we are aiming to make the simulation setting as real as possible, to make the encounter as real as possible. But definitely it can be different. We are trying not to make it different, but it can be different from the real world. That's why thinking about global assessment of learners, it needs to have a comprehensive approach that includes simulation as well as work-based assessments. So it's not just enough to assess someone in a simulated encounter, but also to assess someone in real-life encounters, and then you can merge those two findings together to get a better idea of what the person is capable of. But simulation training, for example, in a simulation setting will be better than just training in a real life situation where patients could be at risk for various things, much more so than a standardized patient or a simulated patient, an SP. So these are considerations that educators need to keep in mind. But definitely there can be a gap between the simulated performance and the real performance in a real setting.
There is a comment
Yeah.
said that we must not forget the ethical issues when using real patients in exams, especially pediatric.
Yes, that is, I think, an important concern. And that's another good reason why, for many things, we should think about using SPs. So just this is our next question, and I mentioned it before. Do you think this is a real clinician who is portraying a patient, or is it a non-clinician who is portraying a clinician? We have another poll question for that. So what do you think?
Can you see the poll?
Yeah, I can see the poll. And it's going in one direction or in the other direction. It constantly switches.
Yeah.
Yeah. Okay, well, maybe we'll stop here because we are running out of time very quickly, but these are important discussions to have. So let me stop sharing the results, and I can share the results. So as you can see, a healthcare provider, can you see the results?
Oh,
No, not yet. Okay.
can you see it?
I can see it, but can anyone else see it?
So there are 13.
Maybe now.
There are 13
I think now you can
healthcare
see it.
provider. Yeah.
Yeah,
Okay.
it's visible to us.
Okay, perfect.
Okay, great. So as you can see, the majority thought that it was a what happened here?
Healthcare.
Yeah, that it was a healthcare provider portraying a patient, but actually it was an SP portraying a healthcare provider. So the importance of costumes that will make it more real or less real. But you can see how just difference in garment and the stethoscope around and how this provides a different experience. So definitely appropriate dress code and appropriate, and sometimes moulage is being used as well to make it more real for the learner who is coming to the station. And as I also mentioned before, there is a, sometimes we use a video to illustrate what happened just before the encounter. And then the learner goes into the station and sees the same SP who is on the video. So this is a very brief video that we've used in some professionalism stations. And I'm going to start it. It takes a few minutes to get started. And I want to warn you, it can get very loud. So I hope you don't have any earphones. If you have earphones, put them away. It's an ambulance driver who is asking for a signature, and this is a pediatric resident.
Can you not see that I'm busy? I have a lot of patients I have to take care of. I don't have time to sign this stuff. Go find one of the medical assistants.
I'm sorry. Thank you.
Okay. So by watching this before they go into the station, they primed to get into this scenario as quickly as possible. And so having some brief videos before the encounters can be very helpful, much better than just reading the scenario and the instructions or doorway instructions. So quickly running out of time, but there is some major journals. I'm sure you're familiar with many of them, and some organization like ASPE, I already mentioned it. The Society for Simulation in Healthcare is another one. And some of the key issues that have been addressed in the last couple of decades, last couple of years, really, last decade maybe, is psychological safety and cognitive overload. And these are two important things that we also have to keep in mind when we are talking about developing and running OSCEs. So psychological safety, feeling free to make a mistake or not feeling that you would be judged, is a very important thing. And of course, personal characteristics play a role. Some people are more likely to feel safe than others, or they have different factors that make them feel more safe than others. So that's something to keep in mind. But the social environment is also important. For social environment for the learners as well as for the faculty and the SPs. And the physical environment, how close are people expected to sit next to each other? That can, especially in some cultures, sitting so close to each other might make them feel very unsafe. So these are considerations. And the program design, is there enough time for the different participants to catch a breath, to de-roll, for SPs, for faculty to also change their change their perspectives from one resident to the next, for one learner to the next. So that's also important to keep in mind. So let me see. So maybe some of you have seen this before, the basic assumption that is being used in the pre-brief and the debrief of simulations of all kinds, and it should also be there for OSCEs. So the basic assumptions, which were developed by the Center for Medical Simulation at Harvard University in Boston, they say that all learners are intelligent, capable, care about doing their best, and want to improve. So making this as a baseline for learners to feel that they can, that we understand that can reduce some of their anxieties. Not all of the anxieties, we know OSCEs can be very, 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 very scary. So I was about to ask what is wrong with this scene, but just in interest of time, some of the best practices that I think will show what's wrong here. They are to not interrupt the simulation. So you have the two simulated parents, and then here's the faculty. He didn't sit here on a regular basis, but this is just a staged picture. But obviously, interrupting a simulation, you can see they're still engaged in their role, is not going to be very helpful to for the learner, can be confusing for everyone. It's important to ask the learner to evaluate themselves first. So how did it go for you? That gives them a chance to also critique their performance first before you or anyone else has something more negative to say. Then engage everyone in the room. That's also very important, whether it's a simulated patient or whether it's a real patient. But these are people who are in the encounter. They experience the learner's performance. And it's really a waste not to ask them how things are for them. And also, if they remain silent, then the learner will continue to think, what are they thinking? So engaging everyone in the room is very important from many different perspectives. And then the conversation should be about what happened, not to give a lecture. Lectures are not useful in OSCE debriefings. Because they're kind of wasting the opportunity to discuss a very specific performance that the learner may have, skills that they may have been able to exhibit or not able to exhibit. So it should be a conversation, asking what, what was your goal in this effort, in this encounter, to get the learner fully engaged. And then feed forward. Sometimes it's better to think about the next time you do this in real life or in another simulation, in another station. What can you do differently? So rather than critiquing what went wrong, to think about, to focus on the future performance, to make sure that they continue what they did well. And most people do something well that can be continued or should be encouraged to be continued. And finally, cognitive overload. This is the amount of information or interactions that exceed an individual's capacity to process them effectively, and how to get to that optimal level where it's not too much stress and not too little stress. That is a big challenge for OSCE developers, to get each station just to the right level, that there is enough arousal to get the learner into the performance that will be required in a real life situation, but that it's not too much that would also not create an optimal performance opportunity for them. Very quickly, we have to skip this because we don't have enough time, but think about what will shape the future of OSCEs the most. Healthcare changes, training program changes, educational science insights, technological advances, or is it the OSCE community's culture of improvement and innovation that will push this forward? Or maybe it's something else. So think about that, I guess, after the session, but it's something to keep in mind. So there are tools that are more and more used in OSCEs, like an AI-powered handheld ultrasound stethoscope with programmable sound recordings. So you can use that specific stethoscope with a normal patient, with a normal standardized participant, and you will hear exactly the kind of sounds that you want to share, lung sounds or heart sounds. And here you can see, you can also have a hybrid station where you have a mannequin in addition to a SP who portrays a parent, for example. And you can do the physical exam on the mannequin and talk to the parent, get the history from the parent, for example. There are also wearables. These are simulated body shapes. It would be very hard to get somebody with that with this type of weight problem into an OSCE station, but you have a chance to at least give some physical presence to make it more real for the learner. And these are also wearables, which again provide some sounds, authentic sounds that can be heard. They are worn by the SP, but this, on a physical exam, the learner will hear what they would hear with a real patient. And immersive environments is another important thing that would be important to keep in mind. We are looking more and more at the environment, how the environment will stimulate the kind of skills and the performance that we want to get in a real life situation. So this is some examples. Yeah, this is an OSCE book, just came out in the 2nd edition that I've also been involved in. And there are many different steps. I wish we had more time to discuss how AI can help with planning and implementing OSCEs. And I'm sure some of you may already have experience with it. But we don't really have time for a discussion, but maybe a final thought from Ronald Harden. Which was given at the 50-year OSCE anniversary celebration. and that was about development in medical education, likely to be limited not by technical, pedagogical, or logistic issues, but by a lack of imagination and the ability to bring about the necessary changes. So that sounds like a good final thought from Ronald Harden. I see there is a hand up. Abdul, we're getting to the end, and I think this is a poem. I can share the slides later on so you can read them as well. But just something more we have to finish. But Abdul, you had, let me stop sharing now. And Abdul, you had a question or a comment. So we can.
Yes, I've got in Pakistan, we are using in postgraduate medical examination in College of Physician Surgeons, we are using mannequins and also SPs. But now we are also using the screen-based simulations. And screen-based simulations where we don't need the SPs and we don't need the mannequins, and we are using in surgery and also in emergency medicine. I think this is something very good, where it's cost effective, especially in low middle income countries. I think that's good option. Yeah. Thank you.
Yes. Definitely screen-based simulations are also very valuable, and makes you independent of SPs showing up or being late. We had all those situations sometimes. So definitely that is another good way to deal with scenarios that are maybe not so easily dealt with in a real life situation, in a in-person OSCE. So that's more and more we are collecting different strategies to make things real.
So
yeah, I see there's some more comments.
Yeah, there are a couple of questions on chat. One is, how can we simulate current and future AI role in CDSS and OSCE?
I'm sorry, could you say it again?
How can we simulate current and future AI roles in CDSS and OSCE?
Okay, so that's an interesting question. Obviously, AI is here to stay, and people are using it for many different things. So I could imagine one station, for example, where a patient has asked AI for some help, and then they encounter a clinician, and the clinician will have to communicate with the patient about maybe some findings from that the AI provided that were inaccurate or that were not useful or maybe even dangerous. There's discussions about how sometimes AI parts can suggest some unhealthy behaviors. So that would be one possibility. But there are, definitely screen-based simulations where you can talk to well, it almost looks like a person, but it's an avatar to engage them in sometimes very difficult encounters, like, for example, giving bad news. I know that there are some programs that, especially for those kinds of very difficult discussions, that learners can practice before they talk to a standardized participant in order to gain some important communication skills. So that would be another way.
So there's another one. Can we integrate climate change concepts in OSCE and OSTE for undergrad medical and nursing students?
Okay, that's a very interesting question. And I must say I haven't participated in a climate change OSCE yet, but I can imagine there's specific, once we identify what some of the challenges are that need to be addressed in a clinical context, we should be able to figure out a way to create stations that can target the skills that are needed to manage them. I mean, for example, there are disasters, floods and so on, that are due to climate change. And one could think about creating a station where a flood victim is seen in a clinical setting. And they may have experience some traumatic, situations because they lost their home in a flood, for example. And how can a clinician deal with such a tragic loss in a clinical setting? So counseling them or finding resources for them. That's one idea. I'm just brainstorming, but I'm sure once you identify what are some common situations, some common problems that occur with climate change, you could then easily think about how does it connect with the clinical world, and create stations for that would be important. I developed some OSCE stations related to disasters. Actually, it was psychological aspects of bioterrorism, and we created a whole scenario of a town that was attacked by bioterrorism, and then there were several stations each station addressed a different aspect of people who were victims or people who had victims in the area where the attack occurred. So creativity is an important tool for all OSCE developers.
Perfect. Another question is, considering the current global challenges where many regions are shifting towards remote work due to conflict or instability, how can practical assessment like OSCE be effective conducted online? While theoretical exams can be administered through available digital platform, what reliable methods or innovations exist to ensure the validity and integrity of practical hands-on evaluations?
Mm-hmm. So virtual OSCEs have been around for some time, and there are various strategies that have been developed also before COVID, to try to figure out a way to combine the physical, hands-on exam, maybe with some models that the learner could have at their site, or sometimes it was a physical exam that they do on a person at their site, and the encounter was virtual. So there was various strategies, for example, using a phone to demonstrate the skills of suturing, for example, and then to have a encounter with a surgeon online via virtual, as a virtual OSCE, or actually it can be hybrid. So virtual OSCEs have also been around for a while. For example, doesn't have to be just a disaster situation like we have in some regions, or COVID, but often learners go to different institutions for rotations, and then they still have to come back. Instead of having to come back to the original school to do the OSCE, they can also be done virtually. So I work now on one OSCE, which is done for psychiatry, for psychiatry clerks. So they just start their psychiatry clerkship, and they have an OSCE, and the learners are distributed throughout the country some on the East Coast, some on the West Coast. So they all get the same scenario online with an SP who is online and faculty who is online, and they have to go through whatever the station requires, but it saves the learners to travel just for the OSCE to the individual school where the exam takes place. So virtual OSCE can be just as useful and just as helpful.
So how many OSCE stations would be ideal in your experience?
Okay, so that varies significantly depending on the purpose. We know initially there was a lot of research done about reliability, and of course, if it's a summative exam, we have to be very concerned about reliability, that we can make judgments that are fair to the learners and that are robust. So initially the first OSCEs were, my first OSCE was 25 stations, which is definitely far too much, much too much than what's needed. But I think the national exams that have been developed have about 10 to 12 stations, and that can be quite enough to get a satisfactory reliability. Of course, reliability depends on other things as well, including the rating forms that are being used. We know that global ratings are more reliable than individual checklists because it's a gestalt that often provides a better interpretation, a better recording of the performance than just what was done, what was not done. So usually the best rating forms include both. Some checklists, some specific behaviors that we are looking for, or specific performance skills that we are looking for, but also a global rating. How well did they manage the encounter? How were their communication skills overall? And also SPs, it's very important to get their feedback. And one can ask, for example, a question. If this was would you recommend this clinician, this doctor, this nurse to friends and family? That's often used in real life patient satisfaction surveys, and it also can help here very well to identify who is doing well and who did not do so well.
Sounds good. Another question, how can you hold OSCEs in a large batch of around 2,000 students?
Yes, that is a large number, and it's definitely a challenge. It has been, there are national exams where several thousand people were taking the same stations in different places. So sometimes in the US and in other places, they create satellites so that the same stations are being used and the SPs are being trained together from each site. So they portray the cases in a very consistent fashion. And the faculty is also trained together, maybe virtually, to make sure that they all have the same criteria, follow the same criteria, and have the same observational skills, and also try to manage their biases as much as they can so that it becomes a fair assessment. But it's difficult. But if it is for a formative assessment, there are other strategies. For example, you can have a peer evaluator. So, or you can go have them move in groups so that you have multiple stations in its groups, 5 stations, a group of 5. Each of them has an opportunity to be the interviewer, to be the exam interviewer in one station, and the rest of the group will learn from observing and from providing feedback afterwards in discussing the scenario. So there are different strategies it can be done. And
One last,
of course, sorry, we also talked about virtual, screen-based evaluations. So that is another way to scale up your efforts, definitely. Yes, sorry.
One last question. Do you think that workplace-based assessments are gaining ground and replacing OSCEs, or each assesses different aspects?
Well, we hope that they are not assessing different aspects, but definitely work-based assessments are definitely gaining ground. For example, in the US, the national board exam has been, the simulation-based board exam has been eliminated altogether, not because it wasn't good, but it was expensive. And so there are economic factors that were after COVID, which of course provided some challenges with travel and with in-person encounters. They took that as an opportunity to just eliminate them because they are expensive. But and it looks like work-based assessments are not so expensive because you have the patients, you have the clinical situations there, and you can just use that as an assessment tool. But of course, we know that patients can vary from situations are not standardized. It is very difficult to, find. You have some ethical considerations, which were mentioned here as well, that we need to be concerned about the real patients. They are there for a different reason, not to be used as an examination tool. So there are many different concerns that we have with work-based assessments. But on the other hand, they are close to the real thing. I mean, that's where learners are going to be. So I think a combination is always the best way to get a good overall, good comprehensive assessment of any individual learner, and to create a learning tool, a teaching tool that is also comprehensive and not just one-sided. I'm afraid we've gone over time, but anyway.
No worries, no worries.
I'm happy to, I love OSCEs, as you will have noticed, so I'm happy to talk about OSCEs anytime.
And anybody have any questions, comments? Last call? No? Thank you so much. Thank you so much. There's so many people who have appreciated your talk, and thank you for giving us your time, sharing your expertise and your knowledge. We really appreciate it. Thank you from all of our CVU family. Now you have become our family. Thank you so much.
Well, I'm very happy to be in the midst of such experienced people who have so many valuable contributions to make to the field.
Elizabeth, come back next year to do a workshop. I've just asked Sakina to seek your permission if you can come back next year and do a workshop for about 25, 30 people.
Absolutely. Very happy to do it.
Perfect.
Thank
you so much. Appreciate it. And everybody, thank you so much for joining, being there on time. And some of you were already on Zoom when I logged in. So I really, really appreciate that. Thank you so much.
Okay. Take care, everybody.
Do you have